Okay, welcome back, everyone. We're going to continue. I think everyone would agree that this has been already an incredibly rich discussion, information sharing, lots to think about for PACHA and just for all of us. One of the things that I hope came out in the prior panels and remarks is that PEPFAR works with an interagency process. And that's really important because it was prior to PEPFAR, that was not how the US government organized. It's global programs, its development programs, but not domestically. It was just not a way that, everything was very agency driven. And PEPFAR, for reasons that Dr. Deibel talked about and some others, really made a different decision to say, if we're going to confront this emergency, we have to do things differently. And the interagency process of bringing different agencies from even different departments together under a coordinator is part of, I would call it part of PEPFAR's secret sauce. And so we wanted to have everyone on PACHA hear from the different agency representatives, different implementing partners, just how they approach it, what their unique, the way that they contribute given the expertise of their agency or department or organization within the US government. We have a lot of people on this panel. No one has slides. It's really just, we're really going to hear from people. I'm just going to read who's on the panel and their affiliation. Everyone, there are bios available to learn more about everyone's incredible backgrounds. So for this session, here is who we have. From the CDC, Hank Tomlinson, who is the director of the Division of Global HIV and TB. From HRSA, we have Captain Alpa Patel Larson, who's the senior advisor for the Office of Global Health. From NIH, we have Diana Finzi, who, as you heard earlier, is the acting director of OAR. From the Peace Corps, we have Kechi Achebe, who's the director of the Office of Global Health and HIV. From USAID, we have Ashley Frost, who's the deputy director of the Office of HIV/AIDS. From HHS, we have Kenshin Reed, who's the acting PEPFAR director at the Office of Global Affairs. And finally, from the Department of Defense, DoD, we have Brad Hale, who's the chief of the HIV/AIDS prevention program. Again, it's kind of incredible to read that all out. I'm excited that everyone has given us some time today. I guess we'll just in the interest of make it easy, we'll start with Hank and just go down the agenda order. Hank.
Yeah, thanks, Jen, and thanks, Patrick, as the co-chairs of the Global Subcommittee for PACHA, for having this session and for having us here today. And thanks to everybody that serves on that subcommittee, but also on the advisory council. I spent the first half of my 25-year career in HIV doing domestic work. PACHA was a familiar name and entity then. What you do is so important, and we're grateful for your contributions. We're also really happy to be a part of it. So I'll jump in. I am going to make a couple of framing comments about PEPFAR as a whole. I think you heard from Becky and from George a number of things that we're focused on programmatically, but also for those that are familiar with PEPFAR and have been here since the beginning, this will be old hat. But for those that might not be entirely familiar, I think there's an important primer that I can maybe put a few more pieces in. And then I'll talk about CDC and sort of our role in this interagency process that is unique and that is uniquely successful and impactful. And so at CDC, the first thing that I should say is many of you work with CDC. They're the nation's HIV prevention arm for the United States, and I am not Robin Neblett Fanfare. So you may see that there is some big difference in the way that CDC separates its domestic HIV work and global HIV work. And that's an artifact of geography, but so many of the issues that we work on are shared across divisions. So Robin and I talk regularly. We try and exchange lessons learned. There's a lot of cross-fertilization and historical movement among our divisions, Patrick included. And so we have a really rich and vibrant connection. But on the global side, we are a group that focuses on global HIV and global TB. Our vision is to like a world where HIV and TB infections are rare, and people living with HIV and people living with TB live long and healthy lives. And we are the nation's public health agency, and we bring a lot of that to the PEPFAR conversation and do specific things related to prevention, treatment, and system support. And I'll tell you about those in a moment. But we, in the interagency flavor you're going to hear about, bring a lot of public health and focus on essential public health services or essential public health functions to that conversation. But the primer, I would say, first is about global HIV epidemiology. And Patrick mentioned one of these data points in the very first lead into the session. But for everyone's sort of orientation, there are just about 40 million people living with HIV around the planet. So 39.9 million was the estimate that UNAIDS provided an update at this summer in Munich. Of those 39.9 million people, 30.7 million, or about 77%, are on antiretroviral treatment. So that's an amazing number. It's quite dramatic considering the rate of change over the last couple of decades. It means that there's a lot left to do. And if you think about the 95 metrics that are a barometer for achieving global incidence and global mortality goals, the world is at 86 awareness of status, 89 of those on treatment, and 93 of those on treatment virally suppressed. So 86, 89, 93. PEPFAR is in 55 countries. My group is in 46 of those 55 from CDC, but about 24 of those 55 countries where PEPFAR works are high HIV burden countries that have generalized epidemics. The remainder, a couple of them are pretty high burden because they're large populations like India, but they have concentrated epidemics, normally among key populations, which for us in our nomenclature means gay, bisexual, and other men who have sex with men, people who engage in sex work, people who inject drugs, truck drivers, and a few others. And so we work, about 95% of our investments are in sub-Saharan Africa, 5% are in from Eastern Europe through Southeastern Asia and the Americans. And we have a model that uses 8 departments and agencies across the US government and hundreds of implementing partners, the vast majority of which are local partners, like homed and located and run by people in the countries where we work to implement services. You saw the slide from Becky, and I think that Jen, I'll cite something that you all published earlier this year with FY22 data. Of the $43 billion that the US government spends on HIV in any way each year, about $7 billion of that is spent on global activity. So about 16% of the USG investments. 4.8 billion roughly is for PEPFAR bilateral programs, 1.6 billion roughly goes to the Global Fund, and then there's a few $100 million for NIH, international or global research. And so with 4.8-ish billion dollars for PEPFAR, that supports headquarters activities across the agencies that are here and some that are not, and really about 4.2 to 4.4 billion dollars of activity at the country level. And so to think that 21 years ago when we were created, you've heard that there are fewer than 50,000 people in sub-Saharan Africa on antiretroviral treatment. Today, PEPFAR supports, through its partners, more than 20 million people on treatment, about 20.5 million at last count. So of those 30.7 million people in the world who are on treatment, 20.5 million of them were supported by PEPFAR, its interagency, our partners, and US taxpayer dollars. So we've got a huge focus on testing, case finding, linkage, retention, achieving viral suppression at the individual level for good outcomes, but also the population level for broad benefit. We also need to have the systems that are strong enough to support achievement of our HIV-related incidence goals, of our HIV mortality goals, and the maintenance or the sustainment of those impacts. And so I think that's enough about PEPFAR, maybe global EPI. You'll hear today from a mix of people that are here from the departments and agencies that are actively implementing. When Mark talked about a central command or a joint chiefs of staff model, what that means is the Department of State, which is where coordination responsibilities live for PEPFAR, works with the other departments and agencies who are implementing programs on the ground to make sure that we are bringing the best of our agencies to bear for maximum impact and maximum efficiency. So in some ways, we might do the same thing because they're core interventions, case finding, treatment, some prevention activities that need to be done everywhere with fidelity to intervention models that produce impact. But there are other things that we bring that we are really good at. And when we all come together, that sum is better and more effective and more efficient than all of its parts. And so at CDC, I would say of the 20.5 million people that PEPFAR supports through its partners on treatment, we support a majority of those, so a little more than 12 million. We also, last year, provided about 36 million HIV tests. We had about 1.1, or a little more than 1 million positive test results, so case finding, and an almost 100% initiation rate among newly identified cases, high rates of viral suppression, accounting for a majority of the impact in the clinical service delivery. And that's something that's different about CDC in global settings versus CDC's prevention focus in the United States. HRSA and CDC were the early treatment partners in PEPFAR and responsible for its dramatic scale up in the early days. The track one transition to local partners, and now USAID and CDC and DoD implement the majority of the clinical service delivery program that, whose achievements I've talked about. Prevention-wise, you'll find a focus on biomedical prevention, condom distribution, some behavioral prevention with adolescent girls and young women and members of key populations. You've heard about our PrEP scale up, which has been really fantastic. We're really committed to that. Independent of those core interventions and treatment, case finding, treatment, and prevention, I would say the things I'd want you to know that CDC does and really focuses on, and some of our special sauce in the PEPFAR mix is those systems that are required to do any of these things, and things that we probably take for granted in the United States, are things that often we've had to work with our host country government partners to build 21 years ago from the ground up. So laboratory, if you need serology laboratory for diagnosis, if you need molecular laboratory for early infant diagnosis and viral load monitoring, if you need advanced techniques to detect drug resistance for HIV and help make determinations about regimen shifting, we've worked to build a laboratory capacity that can move tens of millions of samples around sub-Saharan Africa and other places to work from diagnosis to viral suppression, and then some very exciting work that can often go beyond HIV for broader benefit for pandemic preparedness and response. And so lab systems. The next I would say is characterizing epidemics or characterizing disease spread. So whether it's surveillance or surveys, it's the work we do to understand epidemiology. To be able to efficiently and effectively respond to something or to prevent it, you need to know what it is, where it's moving, among whom, how. And the surveys that you've heard about in Tanzania, we've done, almost 24 of those are either completed or in progress. Those are nationally representative household surveys with tens of thousands of people doing interviews and giving blood draws to help us determine national level HIV prevalence estimates and national level HIV incidence estimates and subnational prevalence. So we can identify where you need to program your resources, and a government that we're working with can do so for maximum impact. It also means we can monitor our success and see what's worked, what doesn't, plan for the future, spread the good stuff that's successful, stop the stuff that may not be. Health information systems and data are required for both accountability purposes for our work, but also to move in the systems that we're talking about. If you want to get a result from a lab to a clinician, a viral load result from a lab, a clinic to a person, if you want to be able to characterize an epidemic and have a system that follows with person level data, like all those systems need to be built. We take for granted in the United States that there's an electronic case surveillance system that follows sentinel events across the lifespan of someone, at risk for living with HIV. Those don't exist in so many of the places where we work, and we've had to create, through surveys, surveillance systems, or approaches, updated things to get that done. Using data is a cornerstone of what we do. Jen posted in the chat during the last session that Q2 data are available in the publicly available Panorama Spotlight, and so you can see our results through March. Actually, Friday and Saturday, our third quarter results were updated. So this is April, May, and June of this calendar year. The first 9 months of FY24 for the US government were updated into our internal USG systems, and they'll be updated into the public system next month. So 3 months after the end of the quarter, you will have, as a member of the public, the ability to see what we're doing at the national, subnational, like very specific levels, and using those data, like Patrick said in the chat, and as close to real time as possible, gets at the maximum efficiency, but also the maximum impact. If we want to interrupt transmission, that's how we do it. Finally, I'd say like clinical service delivery, I've got 100 physicians that work in my group. We've got hundreds and hundreds more that work overseas. Like our ability to sort of build clinical service delivery systems in places where there often were none, that work on HIV but have been able to add tuberculosis, hypertension, mental health and psychosocial support, cervical cancer, and other things, is often a wayfinder for how a system can develop further, and a backbone for future support. So lastly, and I'm over time, I'm going to be really quick. I'd say things that are super important to me and to the people that I work with, and it's not just the public health and essential public health functions and the CDCE things. But part of the fabric of being successful and being responsible in this world is caring about community engagement. It's the core of what we do. We've learned from Ryan White planning councils, from the old community planning groups. We are trying to make sure that civil society and members of community are engaged in every step of every part of everything that we do in PEPFAR. Addressing stigma and discrimination is key to getting people to care about HIV and to want to test, to want to know results, and do everything that follows in the clinical cascade, which is provides a treatment benefit, but also even a bigger prevention benefit. We work with providers to try and reduce provider level stigma. Often the determinants of risk and the determinants of HIV sort of associated. HIV is not evenly distributed in a population. People's acquisition of HIV is uneven, and people's negative outcomes once acquiring HIV are dependent on a variety of factors. And those are the social, demographic, economic, geographic, and political determinants of health. And so we try and address the things that are responsible for public health systems, for responsible service delivery, but to the extent that we can, and it's often so hard. You know how hard it is in the United States. It is doubly hard when you have fewer levers to access in these overseas settings, doing what we can at some of these root causes, which are the determinants. And finally, it's been mentioned before, I want to +1 this. I know Bruce and Monique will talk to you about it more tomorrow, but CDC is all in on U equals U. We have been since 2017 in a consensus statement. This, along with PrEP, they are key ways of reducing stigma and discrimination and returning agency to decision makers, whether HIV negative for people choosing PrEP or people living with HIV and their partners who may or may not be HIV positive with U equals U. It's a game changer. It's revolutionary. It has resulted in appreciable progress, but its full potential has not yet been realized. So we want to make sure in PEPFAR, in global settings, that we do everything that we can to sing this truth, because when its potential is fully realized, the results will be remarkable. So that's a flavor of what we do. Thanks for the extra time. The primer I thought was important. And
Thank you, Hank.
Yeah.
That was great. Let's go on to HRSA next. Captain Patel Larson, please.
Sure. No, thank you so much, everyone. Hank did actually a really good job of providing a little bit of that primer, and I'll touch on that as part of my comments and thoughts as well. Going back to the history and the early ons that Dr. Dybel had really had Mark had really expressed well. And as well as building on what Dr. Bonnell and that Becky and George also had described as that history. So thank you really for this opportunity to speak with you about our contributions globally. Some of this won't be new to many of you, and some of this might actually be, as Paul mentioned, very something that may be new to you today. So HRSA does focus on advancing health equity by improving access to high quality care for underserved populations. So we serve tons of millions of individuals through 90+ programs and thousands of grantees through extramural funding. And so working both domestically and internationally, we do support those investments to accelerate and sustain long-term chronic disease support, including HIV, and that includes efforts to integrate HIV into primary care, especially in rural communities, or expand the health workforce and support gaps in maternal child health or behavioral health in those populations most in need of access to this quality care. And we also support the HHS efforts to advance the use of telehealth, which is another game changer, especially with the last pandemic with COVID-19. And that really does make a difference in increasing access to care to more, as well as making it more accessible where you need it, when you need it, and specialized services more routinely. So aligned with HRSA's mission, our program works just not just across the agency of HRSA in partnership, but also in partnership with the entire federal and other governments, as Hank also mentioned. We also work with civil service organizations, academic institutions, many other public, private entities to really end this HIV epidemic as a public health threat. So within HRSA, where the PEPFAR program is in the Office of Global Health under the Office of Special Health Initiatives. And we support PEPFAR and other global health activities. We were previously under the HIV/AIDS Bureau a few years ago when we combined, since PEPFAR did bear out of the Ryan White program. And we worked very collaboratively on many efforts. And I'll go through a couple of examples of how that bidirectional learning really led to both where Ryan White is today, as well as some of those early and more recent lessons in PEPFAR. To see and to really talk about how continued bidirectional and multi-directional sharing and lessons learned are so critical and to accelerate and sustain the gains as mentioned earlier. And so as part of the Office of Global Health, we really help guide those global engagements and solutions to improve health outcomes in the US and worldwide, and have contributed. So between attending the Ryan White HIV/AIDS conference last week in Washington, D.C. and the International AIDS Conference last month, there's never been more of a push to really learn and share from each other, but not just in a bidirectional way, but in a multi-directional way, as Admiral Levine and Assistant Secretary Pace mentioned. And over the last couple of years, we've really accelerated our efforts in partnership across HHS and through the HHS HIV Bidirectional Learning Forum is one example, and also with NIH as part of a global health reciprocal innovation efforts. And as mentioned earlier, the way that PEPFAR was set up from the very beginning was unique because it required that collaboration and transparency across the board to have this incredible impact and where it needs to go going forward to reach those 2030 goals. And some of the things that we had talked about last week at Ryan White, including this session where we're highlighting or detailing these recent efforts, was that there is actually quite a big community of current Ryan White providers that have earned their chops in PEPFAR, and they express directly, how can we get some of those incredible lessons learned that PEPFAR has really done to have the type of impact it's had in multiple countries, within countries, but across multiple countries, and how do we bring it back to the US? So I was really excited to have this opportunity in PACHA to really see how we can even accelerate our collaborations in getting that information shared in more real time. And I'll to help set that stage also is to I'd like to highlight a few key areas of where that back and forth has already happened and where we can, some new areas where we can look at. So Ryan White was authorized in 1990, after very similar behind the scenes efforts built over many years prior to the existence of this national program. And it was the largest federal program designed specifically for people with HIV in 1990. But while PEPFAR is the largest commitment by any nation to address a single disease globally. So how did we have the domestic expertise and strength feed in? And so the first decade really contributed to that track one. So that building local community advocates and that community leadership, the capacity for service delivery. Some of you might remember the partnership agreements and those, but it was really around the importance of those clinical guidelines as new treatments came over, as really simplifying some of those guidelines to increase access to care faster. There was too many delays and access points that lost so many people into care and getting on treatment because they just weren't sick enough. And it wasn't until there was a lot of efforts to change both the case definition of HIV with the testing algorithms for diagnosis to get people to ensure people were able to have, people living with HIV were able to have access to the treatment that was available. And that there's nothing more frustrating than having available treatment but can't accessing it or afford it. And those were some of those clinical policy guidelines and those changes that had to happen in order to ensure access to care. And there's still some work to do, but really addressing those initial large scale inequities and how it was structured. performed made a difference. There's also a focus on workforce or specialized training of services with medical and nursing students. We called it NEPI. There's so many offshoots from those early programs that exist today. So in total, like those human resources, the treatment algorithms, those best practices, those lessons learned from Ryan White were used on this global scale to really accelerate that development of tailored national treatment guidelines, clinical standards of care, rapidly build up this capacity of health workers, and really create these technical assistance frameworks across the interagency. HRSA doesn't have field staff, and that requires even more collaboration and interagency support to ensure that technical assistance support is able to really bolster that capacity of local partners, of governments, and with the intent of transitioning PEPFAR programs from US-based organizations to sustainable country-led programs. And so that stronger foundation for person-centered care, the importance of quality improvement, as I mentioned earlier, the integration of these HIV services into primary care, reproductive care services, as well as the flip side, integration of more primary care into HIV services for one-stop shop that really changed how people were able to access services when they need it. There's remote skill sharing for complex case management for improved health outcomes for viral suppression. There's the use of telehealth and really expanding that and sustaining those like sustained impact of US government investments. And the capacity building of not just medical students and nursing students, but different cadres of healthcare workers. Ultimately, all of this also contributed to the National HIV/AIDS Strategy achievements, which also then support WHO guidance, UNA goals, and PEPFAR guidance. And then on the flip side, there's so many benefits that PEPFAR has been able to bring to Ryan White, led by Dr. Cheever, as she introduced herself earlier. And those extensive technical advances, the real-time granular data management for decision-making, and that accountability for best use of limited resources for both cost effectiveness and addressing those access issues. But the important part was that whole of government strategic policies and best practices provided those recent lessons back. And so we really wanted to highlight again, gosh, how quickly those 5 minutes go, my apologies, the effectiveness of task shifting, peer support, community support, and those tailored service delivery models for reaching vulnerable communities. And so we've been working collaboratively to increase the sharing of the best practices using evidence-informed clinical service delivery models, related national and local policies that facilitate the highest quality of care without stigma and discrimination, and removing those barriers to address inequities and decrease those barriers that decrease access to such care and treatment across various communities. And in my last minute going over, I'm going to just highlight a couple of really the newest things that we're working on, increasing the sharing and collaboration forums through our federal partners, like I mentioned earlier, these webinars with HHS, Office of Global Health forums, through governments where we have international meetings with site visit exchanges, such as the African Unions on talking about workforce development, reducing the brain drain and increasing community health worker models. Philippines for quality improvement at the national as well as local levels. With France, even for integration of primary care services that then also help us work with PEPFAR. And then the other part is, of course, looking at strategic health initiatives towards the sustainable programming that demonstrate the importance of these community-led efforts simultaneously to national activities that also reduce stigma and discrimination. And so that was mentioned earlier with PrEP scale-up. We've had huge successes in community models for scale-up of PrEP with high intake in Ukraine, Zambia, and Liberia. We've also been refocusing on trauma-informed care and the integration of psychosocial services to improve health outcomes, and that really helps consistently reduce interruption to continued care. And of course, a strong network of medical, nursing, and health science institutions in our Stripe HIV. With a small amount of investment, we're able to have several dozen partner institutions across the sub-Saharan continent well over 1,200 educators across 30 online modules for HIV, advanced HIV disease, non-communicable diseases, PrEP, and more. And then one highlight, just because of it was mentioned earlier with Congresswoman Barbara Lee, is the importance of the Historically Black Colleges and Universities Global Health Consortium. Just a couple of years ago, we were able to fund them, and their efforts in Zambia and Malawi has been remarkable, whether it's reducing 4 to 6 hours of patient time to 20 to 60 minutes consistently, to expanded use of telehealth technology through super hubs, hub spoke models that Hank talked about, that's also used for lab specimens, and really ongoing reducing stigma and discrimination among timely use of healthcare workers. And the last one I wanted to talk about is the PEPFAR has a prevention program model focused on adolescent girls and young women called DREAMS. And in Malawi, graduates of this set of prevention programs who were empowered to stay or return to secondary school, who met the government community healthcare worker hiring requirements, were trained using the Ministry of Health curriculum, with the HBCU Global Health Consortium adding a youth-friendly service delivery component. And this has led to incredible successes across community health in these districts that have this program. And it's been a triple dividend intersection of health, education, and economic pathways that has really been life, generation, and game-changing. And I really do look forward to this type of collaborations that involved all the agencies for this to be successful, to real and governments across in a sustainable way, that we look forward to collaborating transparently and more of these examples in a real time that really does lead to that continued acceleration of our common goals. Thanks.
Thank you so much. So we have 5 more people and only about 15 minutes. We can extend that a little bit longer. So we can probably go 20 minutes, but let's just try to keep it short. Deanna, you're next from NIH. Thank you.
Okay, thank you all, and thank you so much for having me here. As I am actually the acting director of the Office of AIDS Research at the NIH, and although I'm in an acting position, I will say that the enthusiasm for working with across governments, and especially the thought of working more with PEPFAR, has really been something that I have felt very strongly. And on behalf of the future director, and actually the past director, Maureen, who is on this call now, I want to say that really working with PEPFAR is something that we aspire to do more and more. But here now I want to give you a little bit of a feel for the work that the NIH does and the Office of AIDS Research. So Congress basically established the Office of AIDS Research in 1988, and the mandate is to oversee, coordinate, and manage the NIH HIV/AIDS research portfolio. And we collaborate across U.S. government and with researchers and community groups and global partners to really look for the priorities for HIV and HIV-related research. And NIH is, I keep repeating the word research because that is really what NIH does. NIH is a funding agency, and the overarching mission of the NIH is to seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness. And in turn, the OAR vision is to advance research to end the HIV epidemic and improve health outcomes for people with HIV. And our mission is to ensure that the NIH HIV research funding is directed at the very highest priorities across the NIH. So the main roles of the NIH at this point are of the OAR is to convene, catalyze, coordinate, and communicate HIV/AIDS related research across the NIH to HHS and other government agencies, to academia, and to community and non-governmental organizations. And this is done through different collaborations and partnerships. So how are we connecting right now with PEPFAR? So there are indirectly, the NIH funds over 1,000, about 1,100 awards, projects internationally, with an annual amount of about 600 million. And research is done by the NIH and paid for by the NIH in almost all of the PEPFAR countries. And from the inception of PEPFAR, NIH has supported many projects in collaboration with PEPFAR to enhance research and clinical capacity. So, for example, the NIH can sometimes provide technical expertise on issues related to safety and efficacy and other elements that have to do with PEPFAR. But I feel like we could do a lot better. We could align much more closely. And just recently, Ambassador Nkengasong and several other people from PEPFAR came over to the NIH, and we really had some very nice conversations about trying to align more closely. So that's really a strong background goal. There are researchers all over the United States who are really interested in doing more with PEPFAR. So hopefully there will be closer coordination. Our current PEPFAR focus is to support implementation science research. And the areas that we're really focusing on right now are epidemiology, prevention interventions, including in adolescents and young women, and HIV treatment and care, including the long-acting formulations for both treatment and prevention. And as others have mentioned before, NIH also embraces and encourages the global health reciprocal innovation and how important it is to have collaborations and to go back and forth and enhance what we've learned from one country to the next, whether high income to low income or low income to high income, just there's mutual benefits from all sides. And I wanted also to briefly mention that as with everybody else who we have heard here, the importance of community engagement for the NIH. We are always doing our best to listen to community and to listen to all of you and try to partner in our in the quest to save lives and the HIV epidemic. So in our listening sessions, our take-home messages include one, to disseminate and communicate research findings directly to communities, to involve community organizers and advocates in the research process, and to address the effects of structural racism, transphobia, divisive political rhetoric, and HIV-related stigma on people with and affected by HIV. The input we received from all around us and in these community engagements are really major factors in the development of our strategic plan, which is ongoing right now. We are currently developing the FY 2026 to 2030 NIH strategic plan. So I'll just close by saying that we are really encouraged and hopeful to have new collaborations with PEPFAR, as well as with all of the you all. And I'm here in awe. I'm a basic scientist, so I'm here sort of in awe of all the amazing work that you all are doing. And I really hope that NIH continues to partner, and I hope that we can partner ever more effectively with all of you. So thank you all very much.
Thank you. I'm just going to jump in real quick. I know we have a lot of speakers, and I know PACHA members are eager to hear from everyone. And so we're going to just put a timer on to help with the time. So I just didn't want to throw any of our speakers off. So thank you so much, Damon. And Dr. Cates, I'll turn it back to you. Thank you.
Great, thanks so much. Next up is Peace Corps.
Thank you so much.
Dr. Chepe, thank you.
Thank you so much, Kate. And good afternoon to everyone. It's really nice to be with you all. I have learned a lot since I joined the sessions. So I'm going to just go through three basic things. And I'm Caroline and Jen. I'm really going to keep to time. So I'm going to really talk about three things. I mean, who we are, Peace Corps, what we do, and how we support the PEPFAR work. So I believe most of you are familiar with Peace Corps. I'm often confronted with heartwarming responses with a smile from people once I say I work for Peace Corps. And that smile is followed by, oh, my dad, my mom, my brother, my sister, or myself was a Peace Corps volunteer in 1963 and in country XYZ. But with that, you know, I wouldn't take it for granted that everyone is familiar with Peace Corps. So I'll just give a short opening on Peace Corps. We're also the U.S. government agency. We like to always be specific that we're independent. Our mission is to support interested countries meet their needs for trained people. We also promote a better understanding of America in countries, and on the flip side, we promote a better understanding of Americans back home about those countries where Peace Corps volunteers serve. So our volunteers, our Peace Corps volunteers serve in their communities, in local communities, excuse me, and work in 6 sectors: agriculture, community health development, education, environment, youth in development, and today's topic of conversation in health. So what does Peace Corps do with PEPFAR? So Peace Corps, as my colleagues have mentioned, you know, we're all of us here in this session, we're all implementing agencies of PEPFAR. And so Peace Corps is one of those implementing agencies through our Office of Global Health and HIV, which is the office that I lead. We participate in the PEPFAR program. Our volunteers that reside in the countries, or we refer to our countries as posts, where volunteers serve. They implement PEPFAR programs, specifically supporting the program areas that I just mentioned above, the 6 program areas. But at headquarters where I sit, the Office of Global Health, we support the interagency collaboration, leadership, technical and strategic formulation, as well as the interagency collaborative for program improvement, which is often referred to as ICPI. I think, you know, all of us here, you know, when I look at us, we have our meetings every week, and around the table, I always kind of look at us as a nice cake. And what I mean by a cake, I mean, I don't eat a lot of cakes, but you know, I use this example because you know, there are different parts of cake when you're baking a cake, you know, the baking flour and all the others. But you know, it doesn't matter if you're the flour or you're the baking soda. If you're not in that cake either turns out flat or something. So you know, we all have different roles to play in order to make the global HIV program successful. And the numbers that Hank had mentioned earlier on is really due to that collaboration and partnership between all of us. So for Peace Corps, we're kind of unique. As you know, our volunteers go into these countries to stay for 2 years or 6 months to 1 year. And, you know, they don't live in, you know, posh hotels, they live with the community members. So when they go and are able to support the PEPFAR program, one unique thing that our volunteers bring is that they're trusted. You know, no one has that, you know, suspicion that, okay, they've come to tell us something, and then they go back to the big cities and do the opposite thing. Our volunteers live in the community. So that has really helped the PEPFAR program a lot. So while Peace Corps, we're in 65 countries, and we're implementing health programs in over 35 countries. We're supporting PEPFAR in about 15 countries, 13 of them in sub-Saharan Africa, and the other two outside of sub-Saharan Africa. Our volunteers work really for the PEPFAR program, focuses on providing prevention, education, building HIV knowledge and skills for community. We really focus on the youth and the young people and the mothers. Those are the groups that our volunteers are helping. They're also supporting and creating community demand for HIV testing, HIV treatment continuity, adherence, and linkage to care. And they're also supporting building sustainable approaches to community care for orphans and vulnerable children. So in the last, while treatment, there are different parts of the HIV program that are important, but I'll say, one big support that Peace Corps volunteers bring is really to help with reducing new infections, helping to increase mobilizing for testing. And, like I said, I'm sure lots of us here might be on daily medications, but we know how many times that we drop out of those medications. So if there's no system in place to support you to continue your treatments, those can be, programs can be unsuccessful. So those are the kind of things that volunteers do. And in the last, so far in this year, every year we prioritize, what targets we want, all of us as PEPFAR implementing agencies. And every year, Peace Corps volunteers have really been successful in going beyond whatever targets we set for the year. So happy to share the raw numbers with you, but for time's sake and to be fair to my colleagues, I will stop here and look forward to more collaboration with PACHA and everyone here. Thank you. Over there.
Thank you so much. Yes, I'm going to move right along to USAID. Dr. Frost, Ashley Frost.
Thank you so much, Jen and Patrick. It is wonderful to be here. This is a really energizing opportunity to engage with you all today. So my name is Ashley Frost. I'm Deputy Director for the Office of HIV/AIDS at USAID Washington. I'm a Foreign Service Officer. I've spent 12 years overseas at U.S. government missions implementing PEPFAR programs in our health portfolios and worked through other U.S. government agencies and missions. So I really do spend my career overseas in the diplomacy arm of the work that we do as U.S. government. Let me share just a little bit about USAID as a whole. So USAID is the U.S. government agency that administers civilian foreign aid to countries around the world. We provide development assistance, humanitarian aid, and support global health, democracy, and governance, economic growth and trade, education, and environmental sustainability. Our work is guided by U.S. Foreign Service or foreign policy goals, and it's aimed at fostering global stability, prosperity, and security. It's important for you to have that background so you know what is behind our contribution in PEPFAR, and we really work to bring that much larger platform to bear in our contribution to the PEPFAR program. In our global health work, we do global health programming in 100 countries worldwide across many health areas. Beyond our PEPFAR programming, we work in maternal child health, reproductive health, malaria, tuberculosis, emerging pandemics, and other areas. And the tie that really binds our global health programming is we make sure our USAID health investments are committed to reducing inequities in life expectancy around the world and increasing access to quality healthcare. You've heard a lot about the whole of government expertise that we bring. We bring the best of the best in a diversity of skill sets. For USAID, we contribute expertise in person-centered supply chain, prevention, care, and treatment, integration of HIV programming into primary health care, which is one of our key objectives when contributing to the sustainability of the gains that we have made as a PEPFAR program. Addressing larger structural inequalities that make individuals and specific populations vulnerable to HIV, serving the needs of orphans and vulnerable children in our emergency response that was so critical. And now we are working to transform that program to make sure we have a community-based case management platform to reach young people, not only with ARVs and other HIV treatment services that they may need, but to reach their family members in communities with recalcitrant high HIV incidence still, to ensure we're expanding PrEP services and other referral services that may be needed. And we also work to support adolescent girls and young women through the DREAMS program that Alpa referenced. I'd like to say just one more thing about the whole of government response. You've heard about that diversity of skill set. What I have seen as a foreign service officer is that when we stand with government counterparts in countries that have been heavily hit by HIV, and we stand as a whole of government against or with a partner country that stands as a whole of government. I worked in South Africa for a number of years. When we have a World AIDS Day, it's not the Ministry of Health alone. It is the Ministry of Health. It is the Ministry of Basic Education. It is the Ministry of Sport. It is the Ministry of Social Development. And that partnership that we have is what makes this such a critical diplomacy tool that we are uniquely leveraging through our HIV results. I appreciate what Hank said. That was exactly my talking point. It's the way to remember the scope of PEPFAR's influence. 40 million people living with HIV in the world, 30 million on treatment, 20 million PEPFAR supported. An honor to be here today. I will stop there with 1 minute to spare. Look forward to continued engagement with you all as we move forward.
Thank you so much. I mean, one thing I would say, it's hard to understand like the big role that USAID plays from those short remarks in implementing PEPFAR. So we can probably send around some other things later to show the different roles. Okay, so moving on to Kenshin Reed from OGA.
Right. Thank you so much, Jen. So good afternoon. My name is Kanchan, and I serve as the PEPFAR Director at the Department of Health and Human Services in the Office of Global Affairs. So I did join PEPFAR at its inception in 2003 in the Eastern Cape, South Africa, and just feel incredibly grateful to have had this opportunity to serve with this remarkable program, mainly in Africa and now here in Washington, D.C. As previously shared by Assistant Secretary Pace, the Office of Global Affairs at the secretarial level works on behalf of the Department of Health and Human Services, provides strategic leadership and supports health-related diplomatic engagements with foreign governments, international institutions, and global health bodies on behalf of the technical experts that make up the department. HHS operating divisions work domestically and globally and offer diverse yet specific technical expertise. You've heard from other members of our HHS family, CDC, HRSA, and NIH, and I wanted to highlight the work of two other members who are not here today, the FDA and SAMHSA. The FDA's tentative approval and approval processes, along with the expedited review, have approved over 200 new and abbreviated drug applications for procurement by Global Fund and PEPFAR. SAMHSA has also supported mental health and substance abuse services with several PEPFAR countries. The next phase of PEPFAR will be about technical collaboration and engagement with host country governments and aligning with their public health systems. HHS is suited to provide technical expertise in research and development, epidemiology, regulatory strengthening, human resources and health, information technology, and much, much more. On the road to sustainability, the Office of Global Affairs will continue to facilitate diplomatic engagements and the development of a shared commitment between the U.S. and partner country governments. Such collaboration and relationships on a peer-to-peer basis, whether with ministries of health, local governmental agencies, civil society partners, and the private sector, will be important to address inequities in health services. Equity is a core organizing principle for the U.S. government's approach to global health and global health security, investing in more resilient health infrastructure, improving countries' capacity to balance the demands of health emergencies with essential health services, ensuring equitable access to medical countermeasures, facilitates the availability of quality services to historically marginalized groups. Just to conclude, we are so grateful for this timely gathering with both our domestic and global colleagues. It's been a privilege for OGA to work with this PEPFAR interagency over the past 2 decades, And we will continue to do everything we can to end HIV as a public health threat together with all of you. So thank you so very much.
Thank you. We are catching up with our time. Last but not least, we have Brad Hale from DoD. Thank you so much for being with us today.
Thank you. And I really do appreciate the opportunity to speak to this group, and I appreciate that you've convened this important topic. I'll try to keep it brief, obviously, just to touch on a few points. What does the Department of Defense do within the PEPFAR rubric, and how do we do it? So to touch on the first one, it was appreciated at the beginning of PEPFAR that militaries represent a critical element in global, national, regional security. And the HIV pandemic was greatly affecting them, right? Additionally, in nearly every country, there is, in the public sector, right, there's the Ministry of Health, but there's also a Ministry of Defense healthcare system, just like in the United States, right? And so those two elements were seen to be very important to engage upon. If we're trying to achieve 95s across the board, we have to be able to engage the entire public sector in order to do that. And in working with militaries, it was appreciated, well, who works better with militaries than the military? So the Department of Defense was seen as the critical interlocutor for doing this engagement. And I think that has borne fruit. The military is a specific culture, and we have to be able to understand them in order to engage effectively, which we do. Our portfolio is 45 countries. And like Hank said, we're one of, along with CDC and USAID, we are delivering direct service delivery. We're delivering clinical care directly to individuals. Just a little perspective, though. So in kind of thinking about agency funding, CDC, USAID receive a very large percentage of the overall PEPFAR budget. That's about 90%, and about 10% is sent to the other agencies, and we are one of those. And I think what that means is that as a smaller agency, we have to collaborate effectively with all of the other agencies in order to leverage the wedge of money that we get. So we are collaborating daily with CDC, USAID, HRSA. So this collaboration, I think, is part of what makes PEPFAR so successful. We're constantly talking and influencing each other, I think, positively. Just to say that how we do what we do. So we have different lines of effort, and I would say those lines are military to military. We're working with those militaries to improve their health by reducing the impact of HIV, and then military to civilian. We are delivering care to civilian populations. That military to civilian thing can look different. One, we can deliver care through the military healthcare system, or directly to the civilian healthcare system, working with the Ministry of Health. So we have two sister organizations that do those different tasks. So one, the DoD HIV/AIDS prevention program, is largely tasked with mill-to-mill engagement. That means they're working with the militaries directly and also with the military healthcare system. The other organization, the Military HIV Research Program, is tasked more with a military to civilian engagement directly with the ministries of health. And the reason those things are different is because obviously those require different skill sets and different sorts of organization. So we have these two sister organizations that do that work. I think it's important to kind of keep that in mind. And that other organization, the Military HIV Research Program, was really born out of a research that was pre-existing to PEPFAR. And that's how they were embedded in these communities prior to PEPFAR, and then leveraged, of course, to deliver PEPFAR programming. And I think with that, I will stop, and whatever small amount of time is left, we can have back. So I really do appreciate your time.
Thank you. Thank you, everybody. As you, I think, can see, there's like an incredible amount of breadth and depth to how PEPFAR does its work. I actually don't think I've ever heard a panel with every perspective before, so it was great to have it. We do have some time for questions. We might cut into our break a little bit, but I think that's okay because we're kind of in the home stretch. So I know people are probably tired, but if you have questions, let's take a couple now. Put up your Well, while we're waiting, I have one question, which I think got answered, but I think Ashley mentioned it, or maybe it was, I actually don't remember how often the interagency meets to coordinate. And I believe that's been going on since the beginning. So that's one question, just practically speaking. Yeah.
Every Monday.
Okay.
Every Monday, it's a hours-long meeting every Monday. So
Oh my God.
all the people that have spoken here, we're very familiar with each other.
I mean, actually, Jen, this is a really important point. And so prior to COVID, it was every Monday in Washington, D.C. And so CDC is in Atlanta, not in Washington, D.C. And half of the DoD apparatus is in San Diego, not in Washington, D.C. And so we would come every Monday for those in-person meetings that usually were about 5 hours long each week. And then COVID changed the way that we all work together. And so we've adopted virtual approaches. We still find that there's no substitute for coming together and being in person. So we try to do that periodically, but are maybe averaging once or so a month in person, but still meeting virtually at least every Monday.
Amazing.
And Jen, just to add, this is the leadership team that's meeting weekly, often talking during the week, but we have technical working groups that are, well organized across program areas that are also working through issues and making sure, what needs to rise up to the leadership level does. And then I can speak from the mission perspective at country level. Those are well organized, coordinated committees that often comprise of leadership groups and technical working groups where the interagency meets at least weekly to collaborate on programming.
Thank you. Other questions?
As part of a
Yeah.
Ryan White session last week, of community members that have both PEPFAR and Ryan White experience, they actually asked, how can we meet as frequently as PEPFAR and interagency space programs? So there's very much interest in that type of level of collaboration for EHE. So clamoring for it.
I'm going to keep going because I have another question, and I'll see if anybody else does, and then we probably have time for a break. This didn't get brought up because we had so much to cover, but the COP process, developing country operational plans and regional operational plans, which is the way that PEPFAR in Washington and the missions work with countries to kind of create a plan annually, but now less than annually. If anyone wants to just talk a little bit about that, just to give a flavor of what that is like. And then the second piece, since I just mentioned community, just how I think it's very interesting that the guidance for countries is posted by PEPFAR for feedback from the public before it is finalized. And if you could talk a little bit about that. Thanks. And then there is a question for someone else. Sorry. So whoever wants to jump in on the COPs, a little bit about the COPs and then the community.
So Jen, I'll jump in quickly with COPs, invite contributions from others. I mean, you all may have heard about this process. It's had different shapes and forms and feels over 21 years, but for the most part, it has been a months-long process that really involves data-driven decision-making, and everybody says data-driven decision-making guides their work, and this is actually a promise to you that it has historically been the hallmark of this process. But starting in January, usually concluding at the end of April or beginning of May, it is a process whereby the interagency teams located in a country or in a regional program, so USAID, CDC, DoD, Peace Corps, others come together and seek to talk and understand, now with host country governments, with civil society and other partners, epidemiologic trends in country, unmet programmatic needs, and to figure out how to program with US government resources, considering the contributions from others, the Global Fund, the host country government, other donors maybe, how we would meet those needs to most effectively reduce HIV incidence and HIV-associated mortality, and to strengthen the systems that support achievement and maintenance of both those things. Countries have different priorities and countries have different needs, and this is a tailored process that allows folks in context on the country platform, like our locally employed staff, some US direct hires, to come together and figure out and chart that way forward using data to iterate constantly with, will this achieve the goal? How much does it cost? Okay, that's over budget. Let's do the next thing that gets the greatest impact, where it's needed most. And so it's reviewed and signed off and then implemented in the following fiscal year, which starts a handful of months later.
Great. I actually did see Marlene, you had your hand up, and then Dafina has her hand up. So if you want to just quickly ask questions.
No, I think Dafina can go ahead and go, because I believe Elpa sort of answered the question I had indirectly. Just want to say how amazing it is that, despite these very complicated agency structures and obviously government bureaucracies and context challenges there, it's amazing the work that's being done and implemented, and certainly sort of sparked some light bulbs for me about how some of those lessons can be applied to the work we do right here in my home state. So just appreciated the conversation. Thank you.
Thanks, Marlene. I'll jump on in. Is that all right, Jen? So really wanted to ask, thank you all so much, and really appreciate the conversation around the interagency work. I'm listening to this conversation with an ear to what we can learn for the work specifically here in the Southern US. And so would really like to hear the couple of things that popped out for me is, Hank, as you were talking about political determinants of health, and we're talking about the realities of the further marginalization of communities most impacted by HIV here in the Southern US. And then Dr. Achebe, as you were talking about the Peace Corps and thinking about the beauty and the long-held respect and workforce development piece of the work of the Peace Corps, would love to just hear from you all what lessons you feel like we could bring into our work here domestically, since you all clearly are talking to one another, and so excited to hear about the EHE conversations in line with that. Would just love to hear your thoughts as we're thinking about what we can learn and what we can apply here in the Southern US.
And then before anyone answers, Carol, do you want to just quickly ask your question, and then we'll let folks answer and then call it, wrap up the panel?
It's a similar question, and it also, I think it's one of the points of discussion that we had in the global subcommittee in planning for this. Is how can the successes of PEPFAR be translated into the U.S. And so it's that same thing about how did this whole interagency collaboration, which I'm familiar with some very concrete examples. It really, we didn't hear examples, but I know it works. How did it start? Like, in other words, was it always this way? Was this part of the design from the beginning? Was this a development that happened? Because clearly this is not how things work in the US. And so how can we learn and take those lessons into the US, right? Like, how did it get going? This every Monday meeting. I'm not suggesting that, but something like that. How did it get started?
So we got a similar question, and if anyone, a couple of people want to just respond, I think we too as PACHA can kind of think about this going forward. Yeah, I know some of the people that have been doing this for a long time.
Hank, I'll turn it over to you to start and how.
Thanks, Katie. Yeah, so to the first question, so thanks for that. And that's something that we think about a lot, and it's sort of the bidirectional opportunities for learning from each other. And in particular, I mean, the burden and disproportionate impact in the Southern United States is top of mind, especially for my colleagues that work domestically. I'd say some similarities are ways of thinking that are relevant in both our global context, but also the one that you asked about in the American South. One, HIV doesn't exist in a vacuum. It's not like whatever determines HIV risk or HIV acquisition or outcomes after acquisition, like there are a variety, like it's a broad set of determinants that likely affect that other thing. So addressing syndemics, addressing co-occurring issues, addressing some of these root causes are likely to be required to make progress, where there are just so many really deep-rooted obstacles. So HIV isn't a thing by itself that alone has solutions that will get you to the finish line. You have to consider a number of those other factors. The second is working in concentrated epidemics is really hard. The global progress that you heard about, the 86, 89, 93, and 20.5 million people on treatment, most of those numbers and those great percentages come from high burden generalized epidemics where it's just, the person next to you, the person in the house across the street, like just there is a different kind of pattern of distribution for HIV in concentrated epidemics like that we have in the United States. It is the most vulnerable that are affected, and they are the ones that are most deeply sort of, I think, caused by those root cause factors that we've discussed, and it's harder to work. And so I think what we seek to do is in the setting, so when we achieve amazing progress at a national level, and we have some countries that are at 95, 96, 96, we know that despite that national progress, that there are groups with disproportionate impact who aren't experiencing it in comparable ways. And so we in our own programs, I think, seek to solve the same problems that the American South does. And then the third thing that I would say, and this is what I talk about, and we have a lot with our domestic colleagues at CDC, the use of data in as near real time as possible for swift action. And so, our resources are never guaranteed. We've appreciated the EHE resources domestically across jurisdictions and across agencies. PEPFAR resources, you've seen some of the issues that have been prominent over the last year, but to the extent that we can monitor our work, iterate for maximum impact, and understand how impact is associated with efficiency, we can target those resources to exactly the right places and spend them on exactly the things that matter. And we can understand epidemiologic need and programmatic unmet need if we've got the sort of measurement approach and the expectations for hasty reporting and use of those data in real time or near real time.
Thanks. So we are out of time. And we also want to give everyone like a 5-minute break. And we just have one more panel, which is really going to be so interesting because it's going to be Becky coming back, and then Mike Ruffner, also from GHSD, talking about the future for PEPFAR. And hopefully we'll have a little time to interact with them, but let's take 5 minutes, Carolyn.
That sounds great. We'll see you all at
Thank you, everybody.
4:55.
Yeah, thank you so
Thank
much.
you.
It was great.
Produced by the U.S. Department of Health and Human Services.